Hello again, and everyone. Hello again to everyone, and thanks for joining us for justice-focused tobacco cessation, inequities in use, and cessation. I'm just going to jump right into the topic today. So in the previous module, I spent most of the time making the case that when you are attempting to help someone quit tobacco, what you're actually doing is helping them to overcome a dependence to nicotine. And this is an important point because addictions have their roots in they have their roots upstream to socio-environmental conditions that increase the chances that someone will use a drug, and those same factors independently increase the risk that if a drug is used, that the user will become dependent on it, and those same factors also independently reduce the presence of, the access to, and the quality of dependence treatment. Which is to say that if we start from the premise that tobacco industry targeting alone drives differences in prevalence rates, and that differences in prevalence rates alone lead to differences in health outcomes, then we're going to misunderstand tobacco use in those communities, and we're going to be unable to design interventions that obtain the intended results in and for those communities. It isn't the case that tobacco companies target specific groups merely out of some sort of weird hatred to that group. It isn't an intrinsic dislike of racial, ethnic, cultural, religious, or sexual differences that lead to targeted direct mail campaigns. The tobacco companies find vulnerabilities, and then they sell tobacco use as a solution to those vulnerabilities. Any marginalized community is potentially subject to these attacks. And that's an important point because while we make frequent reference to those communities that are historically targeted by the tobacco industry, and we will continue to do so, those are important communities to think about, we need to understand that those communities can change over time. I always like to point out the difference in smoking disparities among Mormons in Utah versus Mormons in my home state of Indiana. When we look at the prevalence rates of each state, we see that Utah's prevalence rate as a state is very low, about 9% or so. And it's even lower in Salt Lake County, Utah. And when I ask people why that's the case, they invariably say back to me, because of Mormons, which is a reference to the fact that the Church of Latter-day Saints has fairly strong prohibitions against both smoking and alcohol. And it's true, those do seem to be a major factor in determining that low prevalence rate. Like, in Utah, there's a pretty good correlation between the density of Mormons in a geography and the prevalence rate in that geography. However, in Indiana, we see the opposite. Mormons have a higher smoking rate than Protestants. Now, my interpretation of that fact is fairly straightforward. In Indiana, Protestants are the centralized majority. Mormons are marginalized. They may find it harder to make friends. They may feel some distrust seeking healthcare, especially mental health care. They may feel more isolated, lonely, etc. They may be less likely to get promoted at work and therefore may lack some of the financial resources enjoyed by their Utah-based peers, including quality healthcare. Which is to say that when we see differences between groups, we tend to treat group features as the rationale for that difference. As with the Church of Latter-day Saints, we see they have a lower smoking rate, and we assume it's some feature of that church that is the protective factor, when in reality, while religious adherence may be somewhat protective, we can't overlook the importance of the larger societal structures that determine susceptibility to different kinds of harms. Similarly, when we see differences between racial and ethnic groups, we tend to gravitate toward explanations of those differences by appeals to genetics or other biological factors. And since we are about to look at some of the prevalence rates and outcome differences that are associated with racial and ethnic categories, I'd like to go ahead and nip that explanation in the bud early. It is most likely not the case that Black, Indigenous, and people of color are biologically more susceptible to use or dependence. In fact, while the evidence here is scant, it appears that individuals from Western Europe are actually more susceptible to use, dependence, and the negative experiences of withdrawal. So when you see differences in prevalence or use, you should know that you're seeing those differences not because of genetic differences, but potentially in spite of them, which leads us to our goals today. In short, I want to talk about some of the differences in tobacco use and cessation patterns in various groups that have been specific targets of the tobacco industry's attention. And I want to talk a little bit about how we might begin to think about tailoring care for these groups. And along the way, there'll be some resources that will get shared as well. And of course, We should start here, right? Over time, through intense public science and public health efforts, the prevalence of tobacco use has dropped dramatically from its peak in the early to mid 1960s. They've dropped from a high of somewhere between 40 and 42% or so to about 13% or so today. And that's about a 70% decrease over the last 60-ish years. But of course, as we'll see, this decline has not been universally shared, and there's a lot of reasons for that. The primary reason, I think, is that important factors that make people susceptible to tobacco use and tobacco industry attention are also themselves not equitably distributed. These so-called social determinants of health include things like housing, food, education, economic opportunities, and on and on. And they all exert a heavy influence on whether or not a child has access to tobacco products in the home. It'll determine if they lack enough adult supervision that they're allowed to engage in regular use. They impact our social groups, our access to care, the quality of care we have access to, and what mitigating or exacerbating circumstances are present to influence us, to encourage or discourage us to seek cessation resources. And they also influence whether or not our prolonged use will develop into a disease, and if it does, whether that disease kills us or not. In fact, as we can see, that while genetics and biology do play important roles in our health, collectively, our social circumstances and our physical environment are together far more important. And the most important thing of all are our specific health-related behaviors, which are themselves formed within the context of our social environmental milieu. Now, I don't want to I do want to get to tobacco use and to some of our specific disparities, but I think it's worthwhile to explore some of these inequitable inputs first for two reasons. One, I want to make clear that these input disparities are real. I think everyone in attendance today probably knows this already, but it's worthwhile, in my opinion, to start out with this sort of fundamental level setting. And the other reason is we really do need to appreciate what our interventions can solve and what they can't. I also want to take this opportunity to say that I don't have a specific section today on women, even though they have been and continue to be a targeted subpopulation. In fact, since the quote seen on this slide here is from one of the pioneers of the public relations industry, it's not a hard argument to make that women were, in fact, the very first targeted subpopulation, and to pretty dramatic effect. To return briefly to this graph, you can see that in the 1950s, women were largely not smoking. And remember, this graph is a graph of smoking prevalence. We know that chew and snuff were used by women at this time, in part because, and this is true especially of snuff, it's inconspicuous, right? Whereas smoking, because of the smoke and the odors, et cetera, is conspicuous. It's noticeable. But you can see on this chart that even after the release of the Surgeon General's report in 1964, which caused men to abandon the habit in droves, women were at the time picking up the habit and at an even faster rate than men were leaving it behind. This growth seemed to plateau through the 70s, and it began to fall after the publication of the Surgeon General's report on secondhand smoke and its impact on children, including its role in sudden infant death syndrome. So while I won't be going into women's patterns of use and challenges with cessation, I do want you to note throughout that I've included a lot of data and information on women, including on this slide. Any discussion of health disparities must include a conversation about economic hardships. Otherwise, it's doomed to be incomplete. And we can see that despite the concerted efforts of generations of women activists from suffragettes to the modern era, there remain pretty stark gender gaps in both wages and wealth, because finances don't start and stop with just wages. Wages, theoretically, would contribute to the accumulation of wealth over time, and wage disparities inevitably lead to wealth disparities. And we can see pretty stark differences between the white population here seen in the third or the second column and the Black and Latino populations in the third and fourth columns respectively. And if you're really just eyeballing this chart, the blue represents the figures in 1983 and the red in 2016. So what we see is that over that period, white wealth has grown dramatically, whereas wealth among African Americans has actually shrunk over that same time period. And as I mentioned in the last webinar, we need to understand that these differences are not inevitable, nor were they accidental, nor are they biologically determined. The economic history of America involves several incidents of deliberately removing from other groups the opportunity to gain wealth, and in many cases, just straightforwardly theft of wealth from those groups. In recent years, I have seen more and more people talking about the Tulsa Massacre and the destruction of Black Wall Street. And if you don't know what I'm talking about when I say those terms, please do yourself a favor and look them up. That incident was actually featured in the HBO Watchmen miniseries. And that's just one example, right? The third bullet on this slide is another one, the reversal of Field Order 15, where federal soldiers literally stole Black-owned land and just re-gifted it to plantation owners. That's another one. And I could fill this slide and probably the remainder of the slides in this presentation with similar events. And there are other examples which have had their effects play out over generations. Many economists, for example, trace a lot of the current wealth of white Americans to those opportunities provided to young white men in the mid-20th century, like the GI Bill, which offered white men the opportunity to cultivate educational capital, an opportunity that was explicitly denied to Black veterans. And then there's the Fair Labor Standards Act, the FLSA. And I know that that sounds immensely dull, but it is arguably the most important piece of legislation that you may never have heard of, or if you have heard of it, maybe you don't know a whole lot about it. I won't be doing an entire exegesis on it. This law, among other things, set minimum wage protections and other kinds of protections for some laborers in America. And I have to be very selective about my words here. This law was passed in 1938, so well before the Civil Rights Act, and only shortly after women had fought for and won the right for the right to vote, or for their vote to be the right to vote to be recognized by the government. This was a horrifically compromised bill, and its legislative history is definitely outside the scope of today's already pretty ambitious agenda. Suffice to say that to get Southern senators on board, certain provisions were added to the bill, and those provisions specifically excluded protecting conditions, working conditions for certain types of labor that was at the time and continues to be done by women and people of color, including home-based, care-based work, agricultural work, and service industry work like waiters. This one bill and its unjust provisions is not the only source of labor disparities in America and everything that flows from those economic disparities, but it is a big part of those disparities, and it has known ripple effects that persist into the current era. And that report on the left is an extremely great resource if you're looking to see how the COVID recession disproportionately impacted women in general and women of color in particular. Despite the lure of new technologies, our world remains a physical one. Houses exist here, but not over there. Houses over here are higher quality than those over there. These houses and not those are more likely to be lived in by their owners. Property taxes pay for schools, and schools largely get kids who live nearby, not the ones that live further away. People live in the same cities where they work, and on and on and on, right? It's a physical world. And as a result, the social determinants of health have a pretty strong relationship to place. And since social environmental vulnerabilities attract the attention of the tobacco industry, we know that the tobacco industry has an interest in place as well. On this map, we see the density of tobacco marketing surrounding WIC clinics. And as many of you may have already heard me say in the past, I'm not one of those tobacco educators that spends a lot of time trying to frame the tobacco industry as quote unquote evil. But sometimes you really do just have to wonder about the humanity of the individuals who came up with the plan of surrounding WIC clinics with enticements to smoke. And of course, it isn't just advertisements around WIC clinics. The tobacco industry disproportionately sends coupons and rebate offers in the mail to low-income neighborhoods. Tobacco retailers are famously more dense in low-income neighborhoods. I know that when we think about tobacco control, marketing restrictions, retailer license audits, we tend to think of geography and proximity and density, but we also need to be thinking about putting our cessation planning onto a similarly geography-first footing. So just to put this into a broader context, I kind of want to walk something through with you together, right? There are a few of you online, so what I would like to do is kind of walk through this thought exercise with us. So we have to understand, of course, that zip code is a proxy for all sorts of things, like the relative health of our literal neighbors, our collective access to good, healthy food, our access to mental and medical care, the advertising we're subject to, our exposure to police interference, how many homes nearby are owned by their residents, and on and on and on. But this effect can be extreme. So here's just one level, or one top level example. In our country, the average life expectancy at birth is 78.8 years, right? So I just want everybody to take a guess on what they think the lowest and highest life expectancies are in Colorado. And don't start guessing yet. There are two jurisdictions here, and I want to introduce you to them if you don't already know about them. So I do want you all to guess in the chat, what is the lowest life expectancy by census tract, by how many years? The only hints I'm going to give you are the names of the towns. The lowest is Edgewater, which is a tiny municipality here in Jefferson County, just west of Denver, my county, where I'm talking to you from. The highest life expectancy is in Kit Carson and Cheyenne Wells. Two municipalities in the same census block, in Kit Carson County, which for those of you who don't know, is straight east down I-70 right before you hit the Kansas border. All three of these towns are disproportionately white, even by Colorado standards, and both are considered low-income opportunity zones. So just in your chat here, what is your guess for what is Edgewater's life expectancy at birth? If you're born today in Edgewater, how many years on Earth are you expected to have? I do have the chat open so I can see people's guesses coming in. I'm not seeing any guesses, which makes me start to wonder if you've all been staring at a screen where I'm silent the entire time. Oh, good. I'm being heard. Fantastic. Starting to see some lowest guesses rolling in. I see 65, 75, 72, 78 in Edgewater. Thank you for those guesses. I'm hoping I can get a couple more in here. I think people were like, oh, Jim normally keeps his camera off, so we're going to keep our cameras off and just go do something else. I appreciate those of you who are rolling in guesses. All right, so I have about 5 or 6 guesses in the chat. So what is your guesses for Kit Carson, Cheyenne Wells? They're the highest life expectancies in all of Colorado. What are your guesses for how long people live if they're born in Kit Carson and Cheyenne Wells today? $93 from Scott. Thank you, Scott. 84. 84 people are hitting 84. I'm starting to wonder if I picked a Googleable answer. I don't actually remember what my the answer that's going to show up on the screen is, because I can't do math on the fly. See a lot of 84s. I'm just going to go ahead and take that as a good average. So just to reiterate, these are 2 places, and thank you those of you who did take a chance to chat in your guesses. These are 2 places, a few hours drive from one another, both subject to US and Colorado policies, both majority white, and the difference in life expectancy between these 2 places is absolutely huge, in my opinion. Residents of Edgewater, on average, die 11.5 years earlier than the average American, and residents of Kit Carson die on average 10.8 years later, and that's a gap of 22.3 years. I can't do math on the fly, which is why I wrote that down in my notes. I could and so from here, thank you again for those of you who participated. I could go on to talk about other social disparities like inequities in education, employment opportunities. We talk about differences in insurance rates, housing differences, access to food, et cetera. But I do want to start moving us getting closer to nicotine. So I want to talk about ACEs, adverse childhood experiences. And researchers initially looked at 7 forms of household dysfunction and the role that childhood exposure to those types of events played in the lives of those children as adults. As you no doubt already know or could guess, exposure to these things is associated with poorer outcomes. And there was a dose response as well, which is to say that the more exposures that a child suffered through, the worse their outcomes were. So again, you probably already know this, or you could guess this. There is a correlation between exposure to these things and lower socioeconomic status, and there's a generational effect as well, which is to say that, for example, exposure to physical abuse as a child raises the probability that the child will engage in child abuse as an adult. Exposure to substance abuse as a child is associated with developing a substance use issue as an adult. And we see an association between ACEs and nicotine use as well. I've already mentioned several times throughout these 2 presentations that this is the type of finding that we absolutely don't need to be surprised by. We really should not be surprised by this. Nicotine dependence is substance dependence. So anything that increases substance use, broadly speaking, should be predicted to have a similar effect on nicotine use and subsequent dependence as well. Nevertheless, it is good that researchers looked into and found the startling and horrifying relationships you see on this slide, where nearly every dimension of a tobacco dependence etiology is impacted for the worst, from early initiation to more experimentation to more regular use and heavier use. So I've been alluding to it throughout the presentation and the last one, but it bears explicit mention that there is no one for whom nicotine dependence is inevitable. Even in the populations with the most extreme prevalence rates, there are both never smokers and ex-smokers there. In fact, in most of the populations that we're about to talk about, the majority of individuals will not regularly use tobacco at any time in their lives. And many who use regularly as adolescents will not grow up to become adults with a habit, problematic or otherwise. Similarly, for those who develop a habit and decide they want to quit, there's no one who is absolutely prevented from achieving that result. Under the right conditions, with the right support, and with the right motivation, anybody can quit. We do see disparities in success rates at the same levels of care, but these are marginal differences. This is not orders of magnitude that we're talking about. Rather, we should be looking at each of the factors each of these factors as contributing to someone's overall chances of these things. First of exposure, then of use, then of experimentation, then of regular use, and eventually disaffection and abstinence. The most important factors are those early upstream contributors to use. The most important factor there being whether a parent or someone else in the house uses tobacco. Such individuals serve as role models and establish norms and other cultural correlates of use. They also serve as willing or unwilling sources of tobacco products. Whether tobacco products are given willingly or are secreted away by tiny hands, this increased access is very important. And the biggest correlates of whether a parent uses are those upstream things that I've already been talking about. And these things, of course, are also associated with ACEs, which we've also talked about. So we can see the mechanisms within mechanisms, creating little feedback loops all throughout childhood that each increase the likelihood of someone using. So at this point, I just want to remind everyone on the line today what the second of the two major points I made in the first webinar in this series was, and that is that our webinar series is on cessation. We can have a debate about when prevention ends and when cessation begins, and we know that there is a sort of a muddy period from ages 12 to 24 or so, where prevention and cessation interventions are probably taking place simultaneously or should be. But at the individual level, things start to really clear up for us. Cessation interventions can only benefit those individuals who are currently using tobacco, period. That's it. I mean, I know that sounds really obvious, but I want to make sure that we're all on the same page. To the extent that some cessation supports are also maintenance supports or abstinence supports, they may have a secondary benefit for individuals who've already quit, but primarily cessation interventions are aimed at individuals who are using tobacco, and we may qualify this a bit to say that they benefit only those who need assistance, right? Because there's a minority of smokers, tobacco users, who really don't need support, but if we're out there supporting it, they're going to get that support anyway. With all that in mind, I do want to focus a little bit on what we're going to move into that second box, right? Not upstream per se, but we are going to be thinking about some of the systemic things that are supporting continued use. And one of those things is implicit bias in general and implicit bias in the healthcare industry specifically. And I'm not going to dive too deeply into implicit bias because the implication of implicit bias is that currently biased individuals aren't at fault for their biases, and therefore they can't be blamed. And personally, I think that lets people like me off the hook a little too easily. So if this is a brand new term for you, I'm going to define it sort of really broadly and maybe a little bit chaotically, I hope in a way that's useful. The premise here is essentially so the world is built a certain way, right? It operates under a certain set of assumptions with certain rules, some of which are explicit rules like laws, and other of which are unspoken. The nature of our world is such that it favors whiteness and wealth and masculinity and shuns each of those opposites. And there's a certain circularity to these unspoken and spoken rules. For example, if as a society, as for some of us who are making the rules in society, for example, if we as a society criminalize the behaviors that certain individuals engage in and then increase our arrest and imprisonment of those activities, we build a world where those individuals are criminals, definitionally. Their status as criminals, wholly created, then justifies the creation of new laws that further criminalize other behaviors associated with those same individuals. This creates more quote unquote criminals and intensifies the association of criminality among those individuals, with those individuals. The association of criminality with those individuals then creates in the minds of others the idea that they are riskier choices for hiring or for housing or for college admissions, etc. This increases poverty rates, which in turn increases the engagement with informal labor sectors, including the black and gray markets, which of course increases the association with criminality. Together, this increases the levels of suspicion and distrust with which others treat individuals from within that community, and so on. So what I've described here seems fairly simple, I think. And while I'm alluding to the circular way in which these ideas tend to reinforce one another, I have mostly described a fairly linear process from the deliberate decision to create criminality, to invent it, and to build from there to broad suspicion and distrust. But the real process is far more complex, with multiple traits being negatively associated with Blackness and poverty and femininity, and their opposite virtues being associated to their opposites. And the functions by which these attributes are reinforced and amplified come from a variety of sources: legal, cultural, political, and others, right? So like everyone, I was created by the daily inputs that I have received from the sociocultural world in which I have always been enmeshed. That said, as an adult, I do have the choice of noticing these implicit biases or ignoring them. I can choose to work on changing them, or I can refuse to do that work. So I'm just not as interested in the implicit bits as much as I am the explicit bits. Your mileage may vary. My personal opinions aside, I think the real presence of implicit bias is unassailably true. And the impacts of these subtle structures have had massive impacts, in part because so many people are a victim to them. And they had been in place for so long that many of their rules and creations form that set of unspoken rules of the world that sets the parameters of what's possible. But I want to talk about how implicit bias might directly impact the health delivery of healthcare. So these two pie charts show us the racial and ethnic differences between physicians on the left and the US population on the right. And I want to point out two things on this graph. The first is the obvious discordance between Black, Latino, and Asian physicians and the corresponding numbers in the overall community. With there being far fewer Black and Latino doctors than individuals in the population, and far more Asian doctors than individuals in the population. The second point is also on the Asian discrepancy. I will talk about this in more depth in the next webinar, but the Asian demographic box, that sort of collection of individuals, is deeply problematic for two main reasons. One of which is that it includes an extremely broad set of countries and cultures. Most of the quote unquote Asian physicians are Indian Americans and secondarily Chinese Americans, which of course is fine in and of itself. This is a function of the relative size of those two source countries, and also their relative wealth and the educational opportunities that that kind of wealth can provide, like the ability to study abroad and travel. But a lot of the Asian smokers are going to be Southeast Asian, which is a function of the very low smoking prevalence rates among Indian and Chinese Americans and the high rates of smoking among other Asian nationalities, and a function of the increased sickness among those who smoke and then therefore end up as patients. So there is a patient-provider discordance within the Asian bloc as well that is somewhat masked by the proximity and size of those two wedges of the pie. So I don't mean this slide to be misleading. It shows psychologists and the US population again. For those of you who don't know, psychologists aren't our main mental health care provider. Those would be our licensed clinical social workers, our licensed professional counselors, certified addictions counselors, other master's level professionals. And they're almost certainly more diverse than psychologists. Still, I thought it was important to notice that the patient-provider discordance here among psychologists is actually significantly larger than the one we just saw for physicians. Now, these patient-provider mismatches may be an important factor of whether Black, Indigenous, and people of color find healthcare providers trustworthy. The literature on this topic is large, or at least large enough that I know that I haven't read as much as I would like to have. But from what I've read, there doesn't seem to be a lot of support for the idea that this patient-provider discordance causes harm or reduces the quality of care. Or at least if it does, that effect doesn't seem to be so large that it overcomes the statistical noise that these studies are designed to study. However, when it comes to whether individuals trust caregiving organizations, whether they choose to go to those sites, whether they go as regularly as they might otherwise, whether they only go to these sites when they have to and not for preventative care reasons, those things I think are a lot harder to know. We do have some evidence from one of the best qualitative studies I know on the topic, that African-American smokers on the Arkansas side of the Mississippi Delta did not call their state quit line because they believed this discordance existed and it mattered to them. Some representative quotes are on this slide. So, one thing you'll note here as you read through these quotes is that the authors didn't include any quotes that mention race specifically. And I don't know if that was a deliberate choice on the part of the authors, or they simply just didn't receive any quotes like that. However, you do see nervousness around accents, around a lack of lived experience, of a lack of local knowledge. And you also see expressions of the rural and urban divide, which is to say that implicit bias, including implicit distrust, can work across many dimensions, not just racial ones. And then it really does or can work both ways. But on that point of bidirectionality, we do need to take into deep consideration that while it is true that providers are making assumptions about the patient due to their traits, and that the patients are making assumptions about their care providers, when it comes to reforming a system, when it comes to reform, the burden is always on the party with the power. In this case, it is the provider's job to make themselves more trustworthy. It is not up to individuals to make themselves more trusting. So now that we have a sense of at least some of the major inputs that lead to tobacco use disparities, let's look at some of those actual disparities. So initially I was going to go fairly rapidly over this slide, but there's a lot of information here and I do want to spend some time on it. We have two data sources here. The first is an MMWR, and for those of you who don't know, these are report services. This is the morbidity and mortality weekly reports that come out from the CDC. This one is called adult tobacco use, and the data itself comes from the National Health Interview Survey, one of 4 major national surveillance instruments that ask questions of representative samples of Americans about their tobacco use. And then the other data source is TABS. This is a Colorado survey. This is actually a report titled Adult Tobacco Use, and then the survey instrument itself is the Colorado Attitudes and Behaviors Survey on Health, which is abbreviated TABS from a title it had a long time ago. The first thing to note here is the difference in the years between the two data sources. So I just want to make that clear. This is not the fairest way to make comparisons between the national and state level figures. Ideally, I would have the national figures from the same year as the Colorado figures, but I wanted to use the most recent data we had from both of these two sources. In general, the trend line for all groups is downward at the national level, which is good news. And if you keep that in mind as you go from column to column, you will see as we go through that while the size of the gap may vary from what you see on the slide, the overall narrative actually doesn't change that much. So for example, among American Indian Alaska Natives, if you imagine that in 2018, the national figure was maybe a few points higher, a few decimals higher, the overall story that in Colorado, the prevalence rate in this demographic is lower than the national figure, that's still true, right? So don't take the gaps to be like particularly meaningful. We're just looking at the overall trends. However, it is worth noting, just a quick comment on the Native American group, that's a really small sample size and it has a very wide confidence interval, which is a word I'm about to say a lot. And if anybody needs me to define confidence interval, just hit me up in the chat and I will take the time to do that. Otherwise, I'll assume that that a confidence interval is sort of a range around the number and the real true number is somewhere in that range. And then with the American Indian figure, that is plus or minus 11.5 points. So it's a very, very, very big range. So, okay, the MMWR, but not the TABS, included the confidence interval. And so taking only the MMWR confidence interval into account, the American Indian and Asian prevalence rates on this table are statistically the same here in Colorado and at the national level. And the white prevalence rate nationally versus Colorado is the Colorado figure is just a half a point higher than the national number, okay? So probably statistically the same there too if we had the confidence intervals for the TABS report. But among the Latinx population and the African-American population, the Colorado figures are well outside the MMWR confidence interval, indicating that just using prevalence rates alone, we should consider these groups to be priorities for outreach and services. Another thing to note here is that the MMWR doesn't break out the Latinx group into Spanish and English dominant subgroups. And that's when you see that slash in the Latinx line for the TABS data, you see 15.4 and 12.9%. Those are respectively the English dominant group at 15.4 and the Spanish dominant group at 12.9%. So we know that at the state level, at least, this is a really important distinction. And that distinction is actually present in the national numbers as well. Moving down the list, we can see that Asian Americans in Colorado smoke at higher rates than Asian Americans nationwide, but as with the national figure, significantly lower than the white non-Hispanic population. So I'll go into a bit more detail in the next webinar on this series on that breakdown, but there could be reasons for this. And actually, I'm going to talk about some of those few reasons when we get down to the Asian American section of today's presentation. So diving into our different groups. So I already shared the cigarette use rates on the last table. Here's a snapshot across tobacco products, and again, at the national level. And you can see that when you look at all tobacco products, the white prevalence rates are higher. And this is largely driven by disproportionate use of ends and smokeless products, mostly the second one. And you'll also see here that dual use is higher among the white respondents. But the two most common dual use patterns are cigarettes plus vape and cigarettes plus smokeless. So this just seems to be reiterating the previous point. And when we reach for an explanation of why African Americans use tobacco at such high rates, or why in Colorado their rates are so much higher than the general population, several important factors present themselves. In nearly every category of inputs with a relationship to tobacco use, African Americans are disproportionately at risk. And we can add to these the general risk factors. We can add to these general risk factors the additional attention given to them by the tobacco industry, which has largely come in the form of intense marketing of menthol in African American communities. Now, this is a conversation that is being had all over the state and in far more depth and detail there than I had the time to devote to it today. And no doubt, many of you or all of you have been paying fairly close attention to the introduction and the death of the flavor ban in Colorado's state legislature. So I'm not going to be repeating any of that information here. The short version is that menthol reduces the unpleasantness of regular tobacco smoking. So it is specifically designed to drive up prevalence rates in populations that would maybe normally avoid tobacco use. I've already alluded to what's on this slide, but the large demographic categories tend to erase or at least hide important disparities that exist within those demographic categories. So for example, while the national prevalence rate between white and Black populations are close, statistically equal at the national level, the gender gap is actually wider, right? Nationally, the gap between men and women is about 4 points, and it's slightly smaller among white men to white women, but not much. What that means is that if the national average is, say, 20 points or 20%, that means it's actually about 18% in women and 22% in men. That's what a 4-point gap means, right? Among African Americans, it's a 7-point gap, meaning that those numbers are respectively 24 and 17%. If prevalence rate is an indicator for prioritization, it's possible that tailoring interventions to African American men would be slightly more impactful than tailoring it to African Americans more broadly. Another key difference here is the difference between the older and younger African Americans in this particular snapshot. At first, I think this can appear misleading. It looks like many African Americans suddenly start smoking at age 50, but this isn't a longitudinal survey. This is a snapshot of use at the time the data was gathered. So instead of thinking this as a trajectory, think of it as a cohort effect. And you have to think about who were these 50 to 64-year-olds when they started smoking when they were roughly 15, which would be about 1985 or so. So what you're looking at here is the last generation of African Americans to start smoking before massive public health protections like smoke-free hospitals, airlines, restaurants, job protections, job site protections, et cetera. And so what you're also seeing there then, because if you look at the white population for the same categories, you see a 2-point drop from ages 35 to 49 down to 50 to 64 among the white population. And that's most likely from people quitting before they hit age 50. So for some reason, whatever incentives or resources that exist for white Americans to stop smoking, those don't seem to be in place for or extend to Black Americans. So I'm going to keep saying it, but prevalence rates are not the only measure of prioritization or risk or whatever. The development of disease and also premature death are also important. In fact, more important. Here we can see 3 conditions, all causally related to tobacco use, and at every age, we see that African Americans disproportionately suffer from the diseases on the slide. Now, we can see that this is true at very young ages, so we probably can't explain the difference to tobacco use at that point, but the gap does get larger as the populations get older. And keeping in mind that the tobacco use rates are roughly equivalent at the national level, we start to see the disproportionate impact arriving to African Americans systemically in a way that they don't reach white populations. So I think the most illustrative example here is diabetes, right? Because diabetes or pre-diabetes can be detected earlier or later. And if it's detected earlier, we can actually reverse it, stop it or reverse it through lifestyle changes, dietary interventions, exercise interventions, and smoking cessation. Smoking causes diabetes and it aggravates its progression. So I think that's that to me that shows a pretty good example of why we need to have better cessation outcomes within this population, because the health outcomes are going to be worse even at the same levels of use. And we see this again when we look at two other disease classes. One is heart disease, right? Smoking causes lots of diseases, but the two most common are heart disease and cancer. When we look at heart disease, we can see that non-Hispanic Black adults actually have a lower rate of heart disease than non-Hispanic white adults. It's not a huge difference, 2 points, but it's present nevertheless, right? And that's what's pictured on the right-hand side of this slide. However, when you look at deaths from heart disease on the left-hand side of this slide, we can see that Black, non-Hispanic Black adults are far more likely to die from heart disease, about 23% more likely to die per 100,000. And the same is true with cancer. On this chart, we can see that both Black women and Black men die from cancer at higher rates compared to the general population. We can also see that despite having roughly equal incidence rates, men disproportionately die from cancer more than women. And this is true in the general population as pictured on the left and in every demographic subpopulation on the right. So moving into our next group. We've already seen the national and Colorado cigarette use rates again. So here's a snapshot of all the other tobacco products. What we don't have here, as previously mentioned, is the tobacco product breakdown for Spanish English dominant groups, which could be a good opportunity for research, local research, and then more tailoring of care. You're almost certainly going to see some major differences between young and old here, and the young and old breakdown roughly corresponds to Spanish and English dominance as well. Now, we'll discuss this a bit more in the third webinar, just as I mentioned with the Asian population earlier. So we'll do a breakdown of the Latino population too. But it's important to remember that whichever term we use, Hispanic, Latino, Latinx, I prefer Latine, these are categories of convenience and political expediency. White America likes to have a convenient shorthand to describe and define individuals who speak Spanish. And because white America treats them as being similar in certain ways, there is a certain political expedience to creating advocacy communities that coalesce around that particular aspect of their identity. But in reality, in the 33 Latin American countries and Puerto Rico, there's a huge variety of cultural traditions, indigenous input, political histories, and those differences present abroad and domestically are reflected in highly variable tobacco cultures here in the US. And we can see, for just one example, that Puerto Ricans and Cubans, right, both Caribbean, Puerto Rico, a Caribbean territory, and Cuba, a Caribbean country, have the highest rates of tobacco use among the Latinx that reside in the U.S. proper, and those numbers are about 34% and 26% respectively. It's interesting that both of these islands have a history of tobacco agriculture. This trend of high prevalence of tobacco use in historically tobacco growing regions is something that we see here in the US mainland as well, with both Virginia and North Carolina, among other southern states, having significantly higher rates of tobacco use than the rest of the country. As with African Americans, we also see really large gender differences as well. For example, the gap between Cuban men and women is 10 points. But this isn't entirely uniform across all Latinx subcategories. For example, while the gap is pretty wide across most of the groups that compose the Latinx category, the gap between Puerto Rican men and women is about 3 points, the same as it is for white non-Hispanic adults. And I don't know for sure how to explain that, except that both Puerto Rican men and women smoke at pretty high rates, and the magnitude of use overall may indicate an overall level of saturation that narrows the gender gap. Another potential factor here is that Puerto Rico is a part of the US, right? Many Puerto Ricans have spent time in the US. Many split their time between the US and the island. And many of those that haven't spent any time here have friends and family that have. Which is to say that although Puerto Rico has a culture and history unique to itself, the influence of America's mainland tobacco culture may be more integrated among Puerto Ricans than it is with other Latinx groups. As with every group, the desire to quit and trying to quit is pretty high among the Latinx population. In fact, I mentioned in the last webinar that about every year, about 70% of smokers say they want to quit in the next year, and about 55% of smokers have tried in the previous 12 months. And here we can see that wanting to quit is about as high, right, at 67%, and having actually made a quit attempt is actually a tad higher at 56%. However, success is hampered by lower rates of insurance coverage, and we mostly understand that to mean less access to medications and counseling. And among those that do receive medical care throughout the year, a much lower percent report having been advised to quit. There are a couple main drivers here, at least hypothetically. One is language, of course, or other cultural capacity. If a provider does not speak the language, speaks Spanish sparingly, or is relying on an interpreter or interpretation service, they may not feel as adept, veering off course, off of the main reason for the visit. Another potential here is, especially when there's a barrier like language, the physician may not feel that a known resource like the Colorado Quit Line, they may not know that the Quit Line provide services in Spanish. We know that when doctors are unaware of cessation resources, or if they don't trust that those would be effective for that particular patient, they're less likely to even initiate a conversation about tobacco cessation. I did not realize I was on the wrong slide, and I apologize. I said I was going to return to some potential explanations for why Colorado Asian Americans are 20-something% more likely to smoke on average than Asian Americans in the rest of the country. So one potential here is that life for Black, Indigenous, and people of color in Colorado is just harder than it is nationally at the nationwide aggregate level. The white population in Colorado have the lowest smoking rates of the enumerated categories, except as compared to Asian Americans and Spanish-dominant Latinx. And that is not true nationally. And African Americans, Latinx, and Asian Americans in Colorado all have higher rates than the national figures for each of those categories. So it's possible that all those risk factors that I talked about at the beginning of today's presentation just exist in Colorado at disproportionately higher rates than they do nationally. Another potential solution is the ethno-nationalist makeup of Colorado's Asian American population. In the US broadly, Indian Americans and Chinese Americans make up the lion's share of the Asian demographic category. And both of those two groups have significantly lower smoking rates than the other comprising groups within the Asian population, the Asian demographic. If Colorado's Asian American group is constituted of fewer Indian or Chinese Americans and disproportionately more from other groups with higher prevalence rates, that could also help explain some of that point difference. So I scanned the American Community Survey on this topic yesterday, and from what I saw, the largest Asian subgroup in Colorado by far is Chinese, either alone or in combination. But there is also a large group of Korean Americans, alone or in combination, that is larger than Colorado's Indian or Asian Indian population. The third highest group here remains Indian Americans, but without more granular data than that, I'm just going to say that it's possible that this difference in the comprising groups may be partially explanatory of the 2-point gap between the Colorado figure and the national figure. As with African Americans, and with at least some of the Latinx groups, there is a pronounced gap between men and women in their prevalence rates. In the actual Asian countries themselves, the sort of national origin source countries, on average, men smoke 9 times more than women. That is absolutely huge, 9 times more, not 9 points more. That gap is smaller among US-born Asian Americans, but it's still pretty large. The national figure for overall prevalence is 8%. We saw that on that table. And this translates to a very small fraction of women smokers in the neighborhood of around 2.5%, pushing the male rate to around 14%, give or take. And of course, as mentioned before, these numbers vary significantly by nationality or national origin, with Southeast Asian and Pacific Islanders surpassing the national average by 6 to 10 points, which is to say essentially more than doubling their risk compared to other groups in the category. So I'm just going to close off this race and ethnicity section before going into 2 more groups. As I keep saying, although we've been focusing on prevalence rates, it is just absolutely critical to understand that prevalence rates just aren't the only disparity of interest here. Prevalence rates are a function both of how many people initiate and experiment with a product and how many people are able to successfully quit once they decide they'd like to. And deciding to quit and succeeding to quit are 2 independent functions, both deriving from norms surrounding tobacco use in social networks, including friend groups, families, and occupational groups. And in the case of succeeding, also the norms of the professional settings in which somebody receives care. or doesn't, right? All right. So I'm going to move into the behavioral health population. And one way I like to visualize the prevalence rates among the behavioral health population, because it's such a huge group. We think of the behavioral health population as comprised of substance users, so people with a substance use disorder on the one side, and also those with a mental health disorder on the other, or mental illness. And those are two huge differences in those group categories, although there's a pretty big overlap between the two of them. But these are two really big groups. And then with each of those groups, there are big differences. There's differences between ADHD and PTSD, and there's differences between a methamphetamine addiction and an opioid addiction, right? So I do like to sort of put them all on the chart as I can. And I like to visualize it as our policies, our protections, our services are leaving individuals in the BH community behind. So we have a big range here between 32 and 60% of individuals with an anxiety disorder smoke. These are smoking statistics. And so using the bottom end of that range, it looks like you can visualize it or think about it as we've sort of left these individuals in 1981. Individuals suffering with an alcohol use disorder, it's like we left them in 1979, again, using the bottom end of a very large range. And here we see major depression going back in time, ADHD going further back in time, PTSD, other drug dependencies, and bipolar disorder are literally capping out the highest known prevalence rates that we've ever experienced. And individuals suffering from schizophrenia are smoking at rates that are quite literally off the charts. But just as is the case with every group with a higher prevalence rate, the desire to quit is the same or higher than it is in the general population. So here we see the general population rate of people who want to quit within the next 6 months in green, or pink for the next 30 days are 40 and 20% respectively. And then across the categories along the bottom, you see that their prevalent or their readiness to quit is actually higher. So for those of you who can't see, the headlines here on the labels for the bars are general psychiatric outpatient, depressed outpatients, psychiatric inpatients, and those receiving services through methadone clinics. So this is a pretty broad swath showing fairly wide uniformity of an increased desire to quit. And in a study that BHWP was able to conduct several years ago, you can see that in drug court participants, so these are individuals who are involuntarily receiving treatment for drug-related issues, they're receiving treatment because of a court order, as is what I'm trying to say here. Prevalence rate is very high, about 75% or so. And among those who use in that environment, who are currently using tobacco, you can see that those who do not have any desire to quit were the vast minority. 35% were what we would call pre-contemplative. The rest wanted to make a quit attempt within the next year. So again, as the prevalence rate goes up, so does the desire to quit. And I mentioned that in the last webinar. And if you don't know what I'm talking about, go back and listen to that. So I want to go into one more final category, and that's the LGBT group. As with that's lesbian, gay, bisexual, and trans. We'll also talk about Q+, right? The queer and other categories. I'll define that in just a second. As with all the groups we've talked about so far, individuals within the LGBTQ+ coalition have been singled out for extra attention from the tobacco industry. And this includes additional tailored marketing and specific outreach. And it's always worth pointing out for those of you new to the field that this includes inclusion in the infamous Project SCUM, right? As it was initially called by the tobacco companies, company before it was rebranded. So in case you needed a little tidbit, a little fact, just to show you what the tobacco companies think of the people that they're marketing to. So in our final category today, there are significant differences between the heterosexual cisgender majority and the LGBTQ+ population. I think everyone here is probably on board with the terminology here, but LGBTQ+ stands for lesbian, gay, bisexual, trans, and queer, and the plus stands for all the non-binary and unlisted categories within the coalition. Transgender means that the individual does not identify with the gender they were assigned at birth or has been imposed on them by society. Historically and etymologically, it indicates that the identity is with the opposite gender in a binary world. So that part etymologically just isn't as true as it is today, because we have a growing appreciation of non-binary identities. But this reading continues to be salient, if for no other reason than it helps explain the suffix cis in cisgender, what I said in the last sentence. As trans means across or other in Greek, cis means same in Greek. So as transgender indicates identifying with another gender than the one assigned at birth, cisgender simply means identifying with the gender assigned at birth. So on this slide, we see some of the increased risk experienced by members of the LGB community. I'm highlighting the fact that the T is not present because the T is here. And on this slide, we can see some of the increased risk borne by members of the trans community. On both slides, there are significantly higher prevalence rates gravitating and toward and surpassing 3 to 4 times the general population. So take whatever the general population prevalence rate is in your territory and then multiply it by 3 or 4 to get a rough estimate of what the smoking looks like within the trans community. In trans populations, we also see the additional increase in alternatives to cigarettes, including cigars, electronic products, and smokeless. And I don't have the comparable numbers for the LGB population. Maybe somebody on the line does. In either case, seeing significantly higher use of non-cigarette products is often interpreted as a sign of a higher risk for dependence, right? Because alternatives are often sought to supplement cigarettes when cigarettes are unavailable, rather than waiting to obtain cigarettes. They're also seen as being identity markers, signaling an attachment to a specific group or culture. And this identity-related behavior cannot be addressed through medications, right? This requires counseling to address. And the thing is, with the requirement here, or not the requirement necessarily, but the increased need for counseling, is that the LGBTQ plus coalition simply has fewer resources designed for them. And the resources that do exist just simply aren't as well trusted. And in any case, they are less likely to be sought out for one or both of these reasons or some other ones. So we are closing in. I just want to do a very, very rapid fire, lightning fast preview of what we're going to be talking about next time. And I know this one was sort of academic and cold, a lot of statistics and numbers. I know that some of you really like that, and I know that others of you really don't. So I hope that the next few slides will act as an enticement for the rest of you to stay tuned for the next webinar. We're going to begin talking about the next webinar. We're going to talk about what we mean by culturally tailored care. When we know that culturally tailored approaches work. So what does that mean? What constitutes cultural tailoring? Do we just need to translate our materials into more languages? Do we have to change pictures in our brochures? Is that the extent of what we have to do, etc.? Then we're going to be laying out some actual strategies and tactics that have been shown to work in diverse settings and serving diverse populations, including the tactic of motivational interviewing, which is a part of a set of strategies we'll discuss on specific treatments. Because what we want to do is make sure that we're designing interventions that support these sorts of specific treatment strategies. And briefly, we're going to be discussing the Empower framework for a public health strategy that can be nimble in deploying diversity-oriented, justice-focused responses. Now, Empowered, as far as I understand it, was initially designed to help systems be responsive to the needs of the LGBTQ plus population, but it can easily be modified in other populations. This won't be all we discuss, but it is where we're going to begin. So that's just going to end me today, and we have a few minutes if anybody has any questions. And you can either raise your hand with the little raise hand feature that's built into Zoom, or you can just type your questions directly into the chat. Well, if there are no questions, I would like to thank you all for your attention. Oh, okay, here we go. Hi, Jan. So Jan has asked if the data use on ACEs and tobacco is relatively new. I would say it's relatively new, but we have had it in presentations going back, I want to say at least 4 or 5 years. And Jan, if you're interested, or if anybody else is interested, we have 2 webinars on our YouTube channel on ACEs. One is sort of an introduction to the concept of ACEs, and the second one is on ACEs and tobacco specifically. So it's more like an hour of just those 2 slides that I showed. Tracy, will you be able to obtain a copy of the presentation? Absolutely. Shortly after it compiles here on my computer, I'll be putting this broadcast up on our YouTube channel. And if anybody is interested in slides, the slides will eventually hopefully be over on the Tobacco Free CO grantee section. I'm seeing a lot of exclamation points and thank you. So I want to return the thank you and the exclamation points. I hope everybody learned at least one new thing. And shortly after this, as soon as I sign off, I'll be sending out the evaluation. And if you liked it or if you hated it, if you thought I got some things wrong or I said things inappropriately, please fill out that evaluation and help us make this presentation better the next time I have to give it. All right, everybody. I appreciate you, and I hope to see you for the third webinar. Tell your friends. We'll talk soon.